Hi all, welcome back to the emergency medicine lecture series. In the previous lectures, I have uploaded the schema for management of a trauma patient, and in that schema, the primary survey and history taking have been completed. So once again, I will repeat the schema. When you see a trauma patient, first of all, you need to do something called as primary survey, which includes the ABCDE approach. You start registration immediately after primary survey. In the primary survey, if you find any problem in one system, you won't proceed further until that problem has been rectified, and then you proceed further. Suppose there is a problem with the airway, you have to manage the airway. Once airway has been stabilized, you will move on to the next part, that is breathing, and so on. So after the primary survey is completed and the registration is ongoing, you will collect a complete history using either ample or the sample mnemonic, which I have discussed in detail in the history taking in an emergency patient lecture. And today we are going to deal with the last part, that is the secondary survey. I am Dr S Prakash Babu, Associate Professor of Emergency Medicine at Karpaganayaga Medical College, Changalpattu. Secondary survey starts after completion of the primary survey and while the registration is ongoing. The main aim of secondary survey is head to toe examination. In primary survey, you did a focused examination to identify the life threatening conditions. In the secondary survey, you aim to identify potentially life threatening conditions, but they're not immediately life threatening, or other injuries that might cause a discomfort to the patient. That is the aim of the secondary survey. It involves complete history taking and a complete head-to-toe physical examination, and includes reassessment of vital signs and repeating the examination once again. Each region of the body is completely examined in turn to minimize missing any injury. So as I told earlier, you have to obtain a complete history using the sample or the ample mnemonic, collect the details of mechanism of injury. This enhances understanding patient's physiologic status. Some injuries can be predicted based on the mechanism of the injury and the direction of force that is applied. Injury patterns can also be affected by age group, activity level, and most recently identified body mass index also plays in the pattern of injuries that the patient will get when a major trauma happens. So let us look at some of the injuries based on the mechanism of injury that you can predict before assessing the patient, and specifically look for those injuries in those particular regions so as not to miss those most common injuries based on the mechanism of injury. So based on the mechanism, usually the trauma can be classified as two types. You all know that. One is the blunt mechanism, the other is a penetrating trauma. Blunt mechanism of trauma usually happens when a heavy object falls on a person, or during road traffic accidents, or fall from a height. So road traffic accidents can be either a rear impact or frontal impact or side on impact. So let us look at what are the injuries that the patient will get when there is a frontal impact. What happens when there is a frontal impact? There are two vehicles coming in opposite directions, they collide with each other. There is a sudden stoppage of the vehicle. If the patient is unrestrained, by kinetic theorem, there is a tendency for the patient to move forward initially and then fall backwards according to the kinetic theorem. So cervical spine injuries are very common in patients with frontal impact. In unrestrained patients, there can be anterior flail chest, myocardial contusion due to steering wheel injuries, pneumothorax, traumatic aortic disruption, fractured spleen or liver, posterior fracture or dislocation of the hip and the knee because of the dashboard injuries, and patient can have head injury if he falls and collides with the dashboard. And most common injuries are facial injuries. A rare impact, when a vehicle is moving, another vehicle comes at a higher speed than the first vehicle and hits it from behind. Usually, the rear impact injuries are less dangerous than the frontal impact injuries because the momentum, that is, the force of impact that is involved, will be lesser in case of rear impact injuries. Again, cervical spine injuries are more common. Head injury can be predicted, and soft tissue injuries of the neck are also very frequent with a rear impact mechanism. Next is the ejection from vehicle, which is very dangerous. Most dangerous mechanism of injury is ejection from the vehicle. When the vehicle comes to a sudden stop, the patient who is unrestrained can be thrown out of the vehicle. There are no particular region of the body involved in ejection, as it is a dangerous mechanism of injury. Any part of the body can be injured. It depends on which part of the body touches the ground first. The patient is ejected and is falling to the ground. In side impact injuries, the vehicle is either stationary or moving. Another vehicle comes and hits it from the side. So contralateral neck sprain can happen. There can be a head injury, cervical spine injury, lateral flail chest, pneumothorax, traumatic aortic disruption, diaphragmatic rupture, fractured spleen, liver, or kidney, depending on the side of the impact. Fractured pelvis and acetabulum can be seen in side impact injuries. Another most common and most dangerous mechanism of injury is hit as a pedestrian. The patient is walking on a ground and was hit by a moving vehicle. Usually head injuries because the patient immediately falls down. There can be chest injuries ranging from traumatic aortic disruption to flail chest to your regular pneumothorax or hemothorax, abdominal visceral injuries, and fractured lower extremities or pelvis can be seen. Fall from the height, usually head injury. The whole spine should be screened even if there is no evidence of any neurological deficit in patients who fall from height. Abdominal visceral injuries are most common. Fractured pelvis or acetabulum, bilateral lower extremity fractures can occur, especially the calcaneal fractures. Injury patterns in penetrating trauma. Penetration means a sharp object which is going through and through the tissues. It can be perforating when it comes out from the other side of the body. Stab wounds to the anterior chest can cause cardiac tamponade if it is within the anatomical cardiac box. They can cause hemothorax, pneumothorax, and hemopneumothorax. If it is to the left thoracoabdominal region, diaphragmatic injury, splenic injury, and hemopneumothorax can happen. Abdomen depends on the level where the object has penetrated the body. So you should know something called as hazardous environment when you are evaluating a patient with trauma. Hazardous environment is the patient has an exposure to chemicals, toxins, and radiation, which are hazardous materials. These agents can produce a variety of pulmonary, cardiac, and internal organ dysfunctions in the injured patients. They can present a hazard to the healthcare providers. Complete decontamination and use of appropriate PPE are needed while attending such cases of exposure to chemicals, toxins, or radiation. The next step is once you collected the history and the details of mechanism of injury and you decided what injuries the patient might have. They're potentially life-threatening, but not yet progressive to the level of life-threatening injuries. The scheme for examination, you should not miss any structure in the body. You have to sequentially examine the head. Start with your two hands behind the head, palpate the oscipitum, and then check for midline cervical spine tenderness, and then follow that over the scalp and the maxillofacial structures, cervical spine and neck, chest, abdomen, pelvis, perineum, rectum, external genitalia, including the vagina, and musculoskeletal system, and ends with complete examination of the neurological system. So let us see one by one what structures you need to examine. When it comes to the head, you need to examine the entire head and scalp for lacerations, contusions, and evidence of any fractures. If there is a periorbital edema is usually due to fracture of the floor of the orbit or roof of the orbit, which forms the floor of the anterior cranial fossa. There can be problems with visual acuity, problems with pupillary size. You need to check visual acuity. Usually in the emergency, when you want to check visual acuity, you can use bedside charts for checking the visual acuity, or you can use, yes, bedside charts, jogger charts. You can use finger counting method or light perception method, depending on how much acuity the patient is having. You need to check the pupillary response, pupillary size, hemorrhage of the conjunctiva or fundi, any penetrating injury to the globe, wearing of contact lenses. They should be removed before edema occurs and makes it difficult to remove and causes corneal problems. Dislocation of the lens is one of the most common problem, and ocular entrapment that can be checked by asking the patient to move the eyes from side to side. If there is an ocular entrapment, that is the muscles getting entrapped into a fractured bony fragment, the patient will not have movement depending on which muscle has involved in the entrapment. Next, you proceed on to the maxillofacial structure. Palpate all the bony prominences, including the forehead, the zygoma, maxilla, and the mandible in total. Assess any problems with occlusion. Examine the intraoral structures. Look for any external soft tissue injuries over the face. All soft tissue injuries over the face which leave a scar or disfigurement permanently will be graded into grievous injury. Look for active bleed which can obstruct the airway. Cervical spine and neck. All patients with maxillofacial or head trauma should be considered as having C-spine injury, and the head movement should be restricted. Initially in the field, you start with manual inline stabilization, and then you move on to put a Philadelphia collar or a hot cervical collar. Nexus low risk criteria or Canadian C-spine rule should be followed and deciding the imaging modality. Look for any cervical spine tenderness, emphysema, tracheal deviation, laryngeal fractures, palpate and auscultate bilateral carotid arteries. Chest, inspect for bilaterally equal movements, flail chest, palpate entire rib cage, including clavicles, ribs, and sternum. Perform a barrel compression test, which is anterior-posterior compression of the chest for looking for any tenderness or any crepitus. Auscultate for respiratory sounds. If there is hemothorax or pneumothorax, respiratory signs will be diminished. Also look for heart sounds. If there are muffled heart sounds or distant heart sounds, non-audible heart sounds, that means there is pericardial effusion. Percuss for hyperresonant or dull note over the lung fields. Perform an E-fast if not done earlier during the primary survey. Next, in sequence, examine the abdomen and the pelvis. Identifying a specific injury is less important than determining an operative intervention is needed or not in case of abdominal injuries. That is your aim during the stay of the patient in the ED. Initial normal examination does not exclude any abdominal injury. Close observation and frequent re-evaluation is required to definitely mark these injuries. Pelvic fractures can be suspected by tenderness to palpation. Perform a pelvic compression test to elicit tenderness. Unexplained hypotension should prompt abdominal evaluation by CECT. Most of the blunt abdominal injuries which cause damage to the mesenteries will not be evident at the initial examination. If patient is repeatedly complaining of abdominal pain and there is no evidence of any free fluid or organ damage by ultrasound, strongly suspend mesenteric ischemia and go for a CT angiography of the abdomen, which will give you any mesenteric injury. Perineum, rectum, and the external genitalia or vagina are examined next in sequence. Your main aim is look for any contusions, hematomas, lacerations, and bleeding at the urethral meatus, which indicates an urethral injury. Without doing a PR examination, per rectal examination, your assessment of a trauma patient is not complete. Rectal examination should be done to assess for the presence of blood within the bowel lumen, integrity of the rectal wall, and the quality of sphincter tone. Vaginal examination can be done in a married woman, assess for presence of blood in the vaginal walls and vaginal lacerations. Do not attempt vaginal examination in minors and unmarried women. Musculoskeletal system, look for contusions or deformities, palpate for tenderness and abnormal mobility. Ligament ruptures produce joint instability. Impaired sensation and loss of the voluntary muscle contraction strength can be caused by nerve injury or muscle ischemia, including that due to compartment syndrome. Examine the back and the whole of the spine. Look for any step deformity and midline spinal tenderness to look for spinal injuries. Then evaluate the neurological system to end the examination. Perform a comprehensive neurological assessment. Include sensory and motor evaluation of the extremities, which is most commonly missed. Examine the level of the consciousness and the pupillary reaction. For assessing the level of consciousness, you can use either AVPU, alert, verbal, pain, and unresponsive scale, or GCS score, which is a bit complicated and can be used in the hospitals. Monitor the level of consciousness at frequent intervals. If a patient with head injury is deteriorating, first thing you need to do is assess the oxygenation and the ventilation status. Any evidence of loss of sensation, paralysis, or weakness is major injury to the spinal column or the peripheral nervous system. So that concludes your secondary survey examination. Then you go for adjuncts to the secondary survey. In the primary survey, you use vitals and vital recording machines as adjuncts to the primary survey. The secondary survey, you use a more specialized diagnostic tests that can be performed with the secondary survey. If the patient is stable, you can subject the patient to extensive radiological examination by sending him to the radiological department. If the patient is unstable, the dire minimum investigations that can be done on the bedside are optimal for patient management. Usually these diagnostic tests include X-ray examinations of the spine and the extremities, CT scans of the head, chest, abdomen, and the spine, contrast urography to find out any urethral injuries, angiography. As I told earlier, mesenteric angiography can be done, transesophageal ESD to find out any cardiac contusions or pericardial effusions. Bronchoscopy can be done to look for any damage to the tracheobronchial tree. Complete cervical and thoracolumbar spine imaging can be obtained without compromising patient care in the ED itself, the bedside. Whole body CT or pan CT has becoming the norm for diagnosing polytrauma in patients suspected with polytrauma. Optimize breathing, ventilation, and circulation during the secondary survey. Continue ongoing resuscitation. Don't stop the resuscitation. Reevaluate the patient repeatedly and closely monitor the vitals. Do not leave the patient unattended, even in the radiology suite when you shift the patient for any CT or MRI examinations. Reevaluation, you need to do it frequently, as triage is not a one-time process, it is an ongoing process. Your assessment of a trauma patient is also an ongoing process. It never stops until the patient is discharged from the hospital. Of course, in the initial stages, you need to reevaluate more frequently As the time goes on and patient gets stabilized, you can increase the frequency, decrease the frequency, and increase the time gap between two assessments. Continuously monitor vital signs and oxygenation by connecting to multi-channel monitor. Maintain a urinary output of 0.5 ml per kg per hour in adults, and in pediatrics, at least 1 ml per kg per hour is the norm. Periodic ABG analysis and end-tidal CO2 monitoring are useful in management of these patients. Assess and relieve pain adequately. Repeat primary survey and secondary survey at frequent intervals. Next comes the definitive care. Definitive care often involves surgical repair of the injuries, usually not done in the ED. You need to obtain appropriate consultations and refer the patients to appropriate specialists depending on the site of the injury and the type of the injury. All patients who need management of ABCs during the primary survey will need further management in the ICU. Patients with head injury, chest and abdominal injuries, major long bone fractures should usually be managed in the high dependency units. Polytrauma patients will require multidisciplinary approach and an early involvement of the trauma team. External transfer. Consider transfer if treatment needs exceed the capabilities of the receiving or the treating hospital. Consider the following carefully when making a transfer decision: the physiologic status of the patient, obvious anatomic injuries, the mechanism of injuries, concurrent diseases, and other factors that can alter the patient's prognosis. Also consider the hospital capabilities, availability of the equipment, resources, and the personnel required to deal with a particular patient. So all trauma patients will have medico-legal aspects, meticulous record keeping with the details like demographic data, mode of arrival at the hospital, assessment and management aspects, exact timing of the events is very, very important. This can be facilitated by assigning a specific member of the team to maintain the records. Chronologic reporting with flow sheets helps the attending and the consulting doctor to quickly assess changes in the patient's condition. So, trauma management is always a teamwork. Not a single doctor or doctors from a single specialty can manage a trauma patient comprehensively, but the size and composition varies according to the institutional protocols. Each institute should have its own protocols prepared for teamwork of a trauma patient. Team typically includes a team leader, an airway manager, trauma nurse, and a trauma technician. The only qualification for the team leader is that they should have an adequate and strong knowledge of ACLS principles. That doesn't have to be the most senior person available. They can. It doesn't have to be a surgeon or an emergency physician or anesthetist specifically. Anyone who has strong knowledge of ACLS principles can be the team leader. Team leader usually checks, directs, and supervises the assessment and the management, and he assigns specific roles to the team members. The team members should follow the assigned roles at the best interest of the patient. Thank you. I think you're liking my lectures. You can leave any comments in the comment section. Don't forget to share and subscribe the videos. Thank you.